everybody. This is Alex Damron. Today I'm going to be bringing you a compilation of the first season of my Don't Rush Breast Cases of the Week, which I share on Twitter on a weekly basis. We're on a little bit of a break right now as I'm actually expecting my third son in 3 days from now, so that's exciting. You can see my other two boys here in this picture. You've got Miles looking into the camera and Preston behind the desk there asking me what a cell is. So I'm training them early and getting them in the right track of pathology. But if you follow me on Twitter, you can see down there it's at @ADamronMD. I post these cases weekly and I kind of show some pictures and let people discuss what they think it might be. And the discussions and the Don't Rush Breast Case of the Week has been growing since we've been doing it. Did it for 14 weeks. So this is just going to be a compilation of those cases in case you missed any and or you want to come and listen to me talk a little bit more about those cases. But if you've seen the cases in the Don't Rush Breast Case of the Week, then you know what's coming. I will timestamp each case in the comment as well as the description of this video, so you can actually go to a specific one that you wanted to correlate with what was on Twitter, and if you want to hear me talk a little bit more just about that particular case in general. So let's go ahead and get started. All right, so we'll get started with our case number one. So this is going to be season one, case number one. And I give just a brief history in all these Don't Rush cases just to kind of clue you in. And as we go forward with the cases of the week, what I used to tell people and what I've told people on Twitter is I show you specific things and I try to illustrate specific things to get you thinking what I'm thinking and to show and demonstrate specific things. I'm not trying to trick you. I want you to learn from these cases as we go through them and learn together, even as people have, put in comments things that are really kind of teaching. And I'll even share a case that someone put excellent annotations on case number 14. But anyway, let's get started with case number one, which is a 2.7 centimeter irregular mass. And this is what you're going to get. And on low power, your first thought is, oh, this is choleliocarcinoma. And that's kind of what I didn't want you to do. And again, don't rush. Let's look at these cases. And the first thing you see is you see abundant acellular mucin with these, clusters of cells on low power. And as we go a little bit higher power, you start to notice a few things that are a little bit different about this case than a traditional carcinoma. And let's talk about a few of those things. And then also we'll talk about just carcinoma in general and maybe why we shouldn't call it that on a biopsy. So remember, this is just a biopsy. But if we look even on this power around these clusters of cells, we notice kind of a clearing around them. And you can also notice a little bit of reverse polarity in the nuclei. Going a little bit closer to appreciate those details, again, you can see the reverse polarity of the nuclei, the clearing around the cells themselves, and also this kind of micropapillary pattern of these clusters of cells. Keep in mind, in traditional carcinoma, you just have these solid clumps of cells that really have a low nuclear grade. So another thing you want to look about in this case, again, look at this nice micropapillary structure right here, but also these nuclei, while I agree it's not overtly pleomorphic, is not totally monotonous and really, really low nuclear grade that you would expect to see in a classic carcinoma. So again, if we're looking at closer power again, not all of the clusters show the clearing around them, but the majority did. And the nuclear pleomorphism is a little bit more than you would typically expect to see in a classic carcinoma, right? Some of these nuclei are a little big, but I do agree the pleomorphism here isn't strikingly, bad. However, it's not really like just a nice monotonous nuclear grade 1, right? So that's kind of what I wanted you to notice about this case. And this was my very first case. Right off the bat, we got great participation in these cases. And honestly, it's been so awesome to watch this kind of series grow and all the support that I've gotten. So I really appreciate that. And again, as I mentioned, the first thing that you think is that, oh, this is mucinous carcinoma. And there's one thing I want to point out about making that diagnosis on a biopsy is one that, traditional classic carcinoma has an excellent prognosis. And anytime you put something on paper, patients are going to look that up, right? They're going to Google it. They're going to say, oh, this has a great prognosis. I should just do fine. So if you call this colloid carcinoma on biopsy, you're kind of giving the wrong message to the patient. And just remember that to truly call something colloid carcinoma, greater than 90% of the tumor has to demonstrate that morphology. So I don't like to even use that terminology on biopsy because you're not assessing 90% of the tumor, okay? And we'll talk a little bit about that on the second slide. So again, as I mentioned out, really pay attention to these micropapillary features, and you notice that reverse polarity that I was pointing out to you on the previous slide. And also that the nuclei are slightly more pleomorphic than what we see in the classic mucinous carcinoma. And as I mentioned, I really reserve calling pure mucinous colloid carcinoma on cases that have a nuclear and a mitotic score of 1. So of course your glandular score is going to be a 3 in those cases, but a 3-1 is going to give you an overall grade of 1. And those have excellent prognosis, but it's really only if you apply those criteria strictly to making that diagnosis. And again, avoid using that diagnosis on biopsy. It's better to say maybe with mucinous features, right? But the difference in this case is that it had micropapillary features. And those micropapillary features kind of, you could say kind of trump the mucinous features, right? These cases are more likely to be associated with lymphatic invasion and lymph node metastasis compared to a typical mucinous carcinoma. That's why it's important to recognize these micropapillary features. And it's actually thought that this particular entity has a prognosis that's in between a mucinous carcinoma and a just pure infiltrating micropapillary carcinoma. And as I mentioned, mucinous carcinomas that demonstrate greater than 10% of another histologic type are no longer a classic mucinous colloid carcinoma, right? They're actually going to have a prognosis that's dependent on the non-mucinous component. All the special types generally in the breast, like micropapillary, pure mucinous, have to demonstrate at least 90% of tumor-specific histology for that reason, because it's often in the breast that we have heterogeneity. That's a very common thing into the breast, is to see heterogeneity within tumors. A few things to note, as I mentioned before we move on to the next case, is that true carcinoma should have very low nuclear grade. Look how monotonous this tumor nuclei population is. Also, these nests are generally solid. They don't have that really micropapillary feature that I showed you in our case. And then if you look at the micropapillary pattern is seen in, a pure micropapillary carcinoma, but also it can be seen in mucinous, tumors that generate mucin production, right? And this micropapillary pattern is sometimes seen in carcinomas that have mucinous production, right? And they have this nice tubule histology. Although our case didn't really have the nice tubules, it had a few that I pointed out, but really that micropapillary pattern is something that you need to recognize. And some people are calling this, infiltrating mucinous micropapillary carcinoma. But again, to give that definitive diagnosis, I can't emphasize enough that you really need to evaluate the entire tumor, which is on excision. So on biopsy, I use the terminology, in this case, I would say, infiltrating moderately differentiated ductal carcinoma with micropapillary and mucinous features, and just signed it out that way, and then wait till you get the excision. Because remember, biopsy at the end of the day is a screening test. We're basically saying, hey, what needs to come out, and when it comes out, let's look at it and determine exactly what it is, right? So you don't have to commit too much, and that's why these criteria of 90% exist, so that you are evaluating the whole tumor before you, assess a histologic type with its, associated prognosis. So let's move on to case number 2, 52-year-old female with architectural distortion. So this is a very interesting case, and what you notice on low power is really no lobulocentric pattern, right? You're seeing all these glands, and you're going to see this, and your first thought's going to be like, okay, this is probably a carcinoma, right? And that's totally a fair thought, because you have glands kind of infiltrating into the fat here. There's no lobulocentric pattern to this. Clearly, these glands are kind of insidiously infiltrating throughout the breast tissue here, so this should catch your eye. And then when you go down on lower power, you're going to even support that theory because, okay, well, these nests are lined by a single cell layer, right? They lack a myoepithelial cell layer. That's concerning. But let's look about a few features about this that are very, very key to this diagnosis. And the first key is that infiltrative pattern, right, and the lack of a myoepithelial cell layer. But also look how bland these are, okay? These are very bland nuclei, and they have this kind of eosinophilic luminal secretion. And you have it kind of trickling throughout the fat here. Again, no pattern. And looking closer, higher power, closer, I guess closer or higher power, not both. But if looking at higher power, you can see these nuclei again, very, very bland, okay, very round, small tubules with no myoepithelial cell layer with this very characteristic eosinophilic luminal secretion, okay. And there's a very key to this diagnosis that we're going to talk about in just a minute, but This is a very characteristic histology. You should be able to recognize this entity on histology before pulling the trigger and calling this carcinoma, because what this is microglandular adenosis. And of course, those two are completely different, right? One's a carcinoma and one is completely benign. This is the only benign entity that's going to lack a myoepithelial cell layer, so you have to keep that in mind. And we're going to look at a few other features about this that's going to help you with this diagnosis. And this week, everyone was pretty good on Twitter. I think almost everybody was right on board calling it microglandular adenosis. Also, I do have a separate case of the month on my YouTube channel that I'm really just talking about microglandular adenosis for like 20 minutes. So you can check that out. I'll try to link that up in the upper right or upper left. I'm not sure where it'll be in this part of the video. So if you want to check that out, feel free to go check that out. And this is one of the major pitfalls in pathology because, again, it's sometimes confused with infiltrating well-differentiated or tubular carcinoma, and that's a fair thing to put on your differential when you see something like this because of that infiltration into the surrounding adipose tissue, which is a misleading thing, and it lacks the myoepithelial cell layer, right? So that's something that is like you're like, oh man, that's a huge pitfall, and it's something you really need to notice because it's not carcinoma, right? And I've seen two cases that were called carcinoma that ended up being microglandular adenosis by the time we got to review the case. It's like, oh, wait a minute. And we're going to talk about a few things that are going to help you not make that mistake. And the first of it, again, is that classic histology that I showed you. Again, bland appearing nuclei, bright eosinophilic luminal secretion, no desmoplastic response. Okay, tubular carcinoma almost always has a desmoplastic response. All right, keep that in mind. Whereas MGA typically does not. That's a very big key. Also, the glands are nice and round, right? Very well tubule formation, right? Tubular carcinoma tends to be angulated, tends to have that desmoplasia, tends to have calcifications. Microglandular adenosis does not tend to have calcifications. Those are a few things that you don't read in the books that are going to help you in that distinction, because some people, you sign out the case before you get your biomarkers, right? The biomarkers may come in as addendum. And so you may not get to the second step. And the second step is to note if you do your biomarkers and you called this infiltrating well-differentiated ductal carcinoma and it ended up coming back as ER/PR negative, HER2 negative, then you need to take a step back, right? How often is well-differentiated or tubular carcinoma negative for estrogen receptor? Almost never, right? Almost never. And that's your key, okay? If you were to do biomarkers and it came back and it was negative, you have to have your light bulb go off and be like, oh man, I need to go look at that case again that I called well-differentiated carcinoma, because it may be microglandular adenosis. And what you can do at that point is do an S100. And an S100 will be really strongly positive in microglandular adenosis. Another kind of backwards pitfall is that 25% of these are associated with invasive carcinoma at the time of diagnosis or recurrence. So just because you see this doesn't mean that there's not an invasive cancer nearby. In fact, in the case that I talk about in my interesting cases of the month, there was an adjacent invasive carcinoma. So keep that in mind. 25% of the time, that is the case. And they've also had studies that have shown that microglandular adenosis is a actual non-obligate precursor to some triple negative carcinomas, where they've shown molecular evidence of the transition from the MGA to atypical MGA to DCIS involving MGA and invasive carcinoma arising from MGA. So it's pretty cool, actually, a little paper, again, referenced in my MGA talk. So again, check that out if you're more interested in microglandular adenosis. So let's move on to case number 3, 48-year-old female with clustered calcifications. All right, so the first thing you're going to see, and of course, anytime you get a case with calcifications, is you want to find the calcifications, right? I do not look at breast biopsy calcifications without radiology. All right, you need to look at radiology and correlate the calcifications you're seeing with the calcifications that they're seeing on the radiology, because there may be benign calcs and there may be malignant counts in the same biopsy, right? So if you have this linear calcification and it's very, very coarse on a radiograph, and then another area that's these little clustered calcifications, and you find your cluster of calcifications and it's just fibrocystic changes, but you don't go deeper looking for that big hunk and linear calc, you may miss DCIS, right? If you had done some more levels, you would have found it. and can't tell you how many cases of that there were no calcs on the original levels. You get levels, and then there's a lesion that's at least atypical that needs to be taken out. So have a low threshold to do levels in breast biopsies for calcifications where your calcs don't match the calcs on the radiograph. Have a low threshold for that. Okay, so let's look at this case here, and what you're going to see is clearly this is DCIS. Okay, we have maybe possibly involving the lobules up here, and chemotonecrosis. This is clearly DCIS, right? We have an expanded duct and a pleomorphic kind of population in here, maybe nuclear grade 2 with chemotonecrosis. But if we move on a little bit around, it starts to get a little bit high grade. Okay, some of these nuclei are pretty highly pleomorphic here. I showed this case, but to me, this is probably enough to just call it chemotype, solid type. But there was a kind of another thing I wanted to point out in this case, and that was, when you start seeing these cases that have a lot of this, it kind of looks like a little reactive stroma up here, and there's a lot of this, perilobular chronic inflammation. Okay, and again, this is more of a higher grade DCIS here, probably a mitosis there. And what I wanted to point out in this case is that when you have a case like this that is more of a higher grade DCIS and there's perilobular, periductal chronic inflammation, that's a clue. Take a look down there. All right, have a look in that area and be sure you're not missing something like this. Okay, and this was a tricky case, right? This tiny little area, and these are actually all tumor cells that are infiltrating into the fat here, and this was a focus of a microinvasive carcinoma, and I wanted to point that out and show you, in these cases that are, one, if it's a higher grade DCIS, pay attention to the surrounding, tissue, all right? Also, if you see that kind of chronic inflammation, maybe some reactive stroma, maybe you should look a little closer because maybe that's a clue that there's something going on down there that's not just intraductal. Okay, and this can be tricky because some of these, are these all tumor cells, right? Or are there some just reactive endothelial cells or even histiocytes mixed with this? I mean, clearly this cell here, pretty atypical, this one, and these ones tracking throughout the fat. But if you are concerned and you're not sure, what you can do is just a simple keratin, right? Or a simple HER2, even if it's HER2 positive, your ERPR would pick these up. And we'll talk about that in just a minute. And that's what I kind of shared in the answer to this case, is that this was the HER2. This case actually ended up being HER2 positive, right? So the HER2 highlighted it very nicely. But a keratin is a simple stain that you can do to pick up these, carcinoma in the fat here. So this was an example of microinvasion, arising adjacent to a high-grade DCIS. So that was really all I wanted to point out in this case. But it has prognostic significance. If you are going to call microinvasion on a biopsy, then they're going to get a sentinel node, okay? And that's going to be the next surgical step in this kind of case, right? If this is the only focus of invasion when they do excision, then there shouldn't be a positive node, but at least you've already picked it up. Now, if you were to do ER, PR, HER2, and maybe this focus of microinvasion went away, and all you had was the H&E, and you weren't still sure, okay, it's okay. You can communicate that and say, this is at least DCIS, foci suspicious for invasion, something like that. If it's just a focus that goes away on levels, you don't have to commit unless you're sure, all right, because the treatment, the next management step isn't going to change much without, if you use that terminology, they're going to get a node. If you say foci suspicious for invasion, they're probably going to get a sentinel node, right? But still, these keratin stains can really help you in these situations to identify these small foci of invasion that, trust me, are difficult for me and difficult for everybody else. This isn't something that's ever going to get easier. These are always difficult cases. These are always cases that you're going to struggle with, and there's just a few things you can use to help you, and a simple keratin is probably one of the best ones. All right, so moving on to case number 4, 59-year-old female with an irregular mass. And this is what you get. You get a core, and you're like, oh gosh, okay, that's not good. And what you're going to see is you see these kind of clusters of cells here. And your first thought when you look at this is probably, this is probably a ductal carcinoma, which is fair, right? These on low power, these look like kind of nests of tumor cells. But let's look a little closer at this tumor. And if you look a little closer, you start noticing that these cells, while they forming these kind of nests, right, are still a little discohesive looking. And, a little bit pleomorphic as well, maybe nuclear grade 2. But these aren't forming nice glands, right? These aren't forming like tubules or glands. They're just kind of these solid nests of very discohesive cells. And looking even on higher power kind of supports that. We almost have this kind of like eccentric nucleus, and some of them very eosinophilic cytoplasm. There's probably mitosis right there. Very, very discohesive within these nests. And that should clue you in that we're dealing with more of a lobular type carcinoma, right? Discohesive cells. The whole purpose of that kind of histology is the, loss of the adhesion molecules. Most often is going to be E-cadherin. Generally, that's the one that's lost. However, other adhesion molecules have been lost in lobulars, right? Because we know E-cadherin, if you do the IHC, is going to be positive in 15% of your lobular carcinomas. But, one of my mentors, Dr. Gutierrez at Baylor, when I was a resident there, she always used to tell me, she says, Alex, if it looks lobular and it smells lobular, then it is lobular. And so I always stuck with that. I said, look, if it looks lobular, it's lobular. I don't really care what the E-cadherin shows, right? So that's something. And you obviously can do a P120 to help support you. Sometimes if that shows cytoplasmic staining and you have the cadherin in the membrane, then that also supports a lobular etiology. So there's other things you can do, but morphology trumps everything. And let's look at this. Most of the people in the discussion this week picked up on the fact saying, the cells looked a little discohesive, and that was right on point, right? But it didn't look like a classic lobular. It didn't have the, single files infiltrating throughout the fibrous tissue. It didn't have the single cells, right? It was more nested. And that was really exactly what I wanted you to notice is that one, it had this discohesiveness, and it also had a little higher degree of pleomorphism than we see in lobular, and didn't have the classic lobular features that we see. Because in fact, this is a special type or a different histologic type of lobular carcinoma, the alveolar and pleomorphic types, right? So these are kind of these nested, almost alveolar type nests of tumor cells that are occupied by this discohesive infiltrating lobular carcinoma. And it is important to be able to recognize the variants of lobular carcinoma because these have a higher propensity to have an unfavorable biologic features compared to classic ILC. And what do I mean by that? I mean higher grade. And when you start getting into the pleomorphic type, you have a higher chance to be HER2 positive, right? Classic ILC is almost never HER2 positive. I think less than 1% of all of classic ILCs would be HER2 positive. So extraordinarily rare. I actually had one recently, and every time you see it, you're like, whoa, that's unexpected. But if you get a HER2 positivity in a more of a pleomorphic or a variant form of ILC, it's not as surprising. And I think that, in my opinion, that these subtypes have, provide the most difficulty in recognition, right? Some people see these solid and alveolar variants and they just say, it's infiltrating moderately differentiated ductal carcinoma. And that's it. And that's the mistake. And what's the difference, right? Well, lobular features are something to pay attention to, right? Lobular types of carcinoma, even ductal carcinoma with lobular features, the variant forms of lobular carcinoma, those do carry different types of things, right? They're much more difficult to excise, right? Lobular carcinoma tends to infiltrate through fibrous tissue in a very subtle way, and them getting imaging of how big the lesion is more difficult than it is a ductal carcinoma. Surgeons may get wider margins in cases that have lobular features or is a lobular carcinoma. So it does have importance to be able to recognize lobular components to a tumor in a prognostic and management standpoint. And of course, the loss of the CDH1 gene in the classic forms of ILC is the same thing in the variant forms. But remember, 15% of these are going to be positive. So morphology, morphology, morphology. And the prognosis of these lesions is going to be related to the histologic grade more than the specific variant type. So if you have a, alveolar variant type that's low, grade 1 nuclei, grade 1 mitoses, it's still going to have a better prognosis than a pleomorphic lobular that's grade 3, right? But these variant forms of ILC have a higher propensity to be those higher grade forms, as I mentioned earlier, and the pleomorphic type in general has a higher propensity to be HER2 positive than classic infiltrating lobular carcinoma. And also, you always think about lobular being ERPR positive, but again, like the higher propensity to be HER2 positive in a pleomorphic type, 5 to 10% of these will also be ERPR negative in the pleomorphic types as well. So keep that in mind. So this is a pretty cool case. So moving on to case number 5, a 49-year-old female with a subareolar mass. This was a pretty cool case. On low power, you notice, okay, well, this clearly has no lobulocentric pattern. Okay, we've got kind of this irregular infiltrating lesion, okay, kind of made of these like long tubules, all right? And if we look a little bit closer, right, we have these kind of tubules. They kind of almost have this little tail to them on some that kind of angulate out. It does have a desmoplastic response to it in the stroma. It doesn't seem to actually be infiltrating into the fat. It seems to be maintained within this fibrous type lesion. And looking on higher power, these nuclei, they're not too pleomorphic, right? We have a little bit of some solid areas maybe. It looks like it has two cell layers, right, if you're looking closely, but the cellulars are a little bit hard to distinguish, but they look kind of like, well, I'd say maybe a little cuboidal, maybe not the best picture to demonstrate. Let's look a little closer. And some areas look like, oh, it looks like it may be squamous metaplasia even. I mean, you could argue that that's like a tadpole-shaped squamous metaplasia lesion. And on higher power, you can clearly see this nice inner layer, okay, luminal-like cells, and you have this outer layer, myepithelial-like cells that have very similar nuclear features to the inner layer, and they're all kind of these nice and well-formed cells. And again, it still has the stromal reaction to it. So what was this? And this is an interesting case, and again, it was subareolar. So many of you were right on point during the week, calling this a serragomatous tumor of the nipple, aka a serragomatous adenoma. And this is a very interesting lesion because it is invasive, right? It's a locally invasive neoplasm, so that's why it generates that stromal response to it. And it consists of, again, those mixed tubules and solid nests that arise in the dermis of the nipple. And sometimes, if you're going to confuse anything with this, it's going to be a tubular carcinoma. But again, tubular carcinomas typically don't have these like long kind of tubules that intersect out. Now, it's going to have the desmoplasia, obviously, but it typically doesn't have these like long tubules as well as the kind of tadpole-like areas that you're going to see in these tumors. And generally, these are actually going to present as palpable masses in the subareolar region. This is a very sensitive region for women. Anything subareolar is going to cause irritation in a woman, right? When it makes the nipple maybe bulge out, retract, or anything like that. Anything that causes nipple change generally is found pretty quickly. And these should be excised. 30% have local recurrence if it's incompletely excised. And although this is considered a local invasive neoplasm, it's considered benign. It has no, it's had no metastatic cases, right? But we should report the margin status because of its chance for local recurrence. So what are some of the features that we talked about? Again, one of the characteristic features of this is that tadpole-like shaped squamous metaplasia nests, right? And that's a very characteristic feature of these. And location, 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 right? And the tubules are lined by greater than one cell layer. Remember, most of our invasive carcinomas of the breast are going to be only one cell layer. The only thing to keep in mind outside of that is, again, microglandular adenosis, which we talked about earlier. These outer layers are generally flattened, okay? Sometimes they can be cuboidal, as I mentioned, like the inner layer, but sometimes they should, most of the time they're going to be flattened and they're going to be positive for P63, just like normal myepithelial cells in the breast, even though they call them myepithelial-like cells. And the inner layers are going to be cuboidal. Again, they can be flattened or squamous, and these are going to be P63 negative. However, the squamous nests, all right, can be positive for P63. So these interluminal-like cells can be positive for cytokeratin 7, while the squamous nests are generally positive for P63. So what you'll see sometimes is, if you have a squamous metaplasia and the kind of tail of these lesions, this whole area may be P63 positive, and then the P63 will kind of go around, and then this focus of interluminal cells here will be CK7 positive. So the lesion characteristically invades around smooth muscle and the lactiferous sinuses of the nipple, but what you shouldn't see are mitoses, okay? The nuclei should be bland, and it shouldn't involve the epidermis or the subcutaneous adipose tissue. If you saw what I mentioned when we were looking at the histology, is that it was maintained kind of in its own little fibrous lesion, right? It wasn't actually infiltrating into the fat. And this lesion is characteristically ER/PR HER2 negative. So remember, tubular carcinoma should always be HER2 positive. And the tubules in tubular carcinoma are going to be more round in shape, and again, always ER/PR positive. But look at these, they're not as kind of comma shaped as the ones you see in the serragomatous tumor of the nipple. So moving on to case number 6, 37-year-old female, so young female, with multiple breast masses. And this is what you get. You say, oh gosh, okay, let me look a little bit closer at this. And you look a little bit closer and you see a granulomatous lesion, and the inner layer of this granuloma is a cyst, small little cyst. And what's interesting about this cyst is that the inner lining of the granuloma is filled with neutrophils. So you've got neutrophils on the inner layer of this granulomatous lesion, and clearly an inflammatory lesion of the breast. And that's the characteristic feature of this. And this is an easily boardable question, okay? And honestly, this isn't the, you know, generally you're going to see a little bit more neutrophils. I think in a classic example, a book example, I think you're going to see, like, if they show you on the boards, it should be, the entire inner luminal lining should be really lined by neutrophils, and it should be abundant neutrophils, because you can have these microcystic like spaces in just breast abscesses even, so that can be confusing. But the classic, granuloma with an inner luminal neutrophilic layer is a very classic feature of a specific type of granulomatous mastitis in the breast that's associated with a specific organism. And that is an easily boardable test, and is a boardable question to show you this and say, what organism is this associated with? And again, you should, if they show you on the boards, you probably should see a little bit more neutrophils in the inner luminal layer, right? We see some here, but this is from the same case. The other granuloma that showed you in the previous picture had more, but you're going to see multiple of these, right? And again, in the history, you say, okay, she's young, so she's got a lower chance to have cancer, right? And she's got multiple breast masses, so unless she's got multiple primaries or metastatic disease to the breast, that's a good clue that maybe this isn't cancerous, right? And when you see it, clearly it's inflammatory. And this is a very classic example of cystic neutrophilic granulomatous mastitis. Even on low power, you can say, okay, this is an inflammatory lesion. It encompasses the entire breast biopsy, but the unique thing is those microabscess formation around lipid vacuoles, creating what looks like an empty space inside of this granulomatous lesion, right? And it's rimmed by neutrophils. So the inflammatory infiltrate outside is consisted of lymphocytes, neutrophils, Langerhans giant cells, forming this granulomatous that's associated with ducts and lobules. Generally, you're not going to see this in the interlobular stroma, okay, between lobules. You're not going to see this. This is going to be associated with ducts and lobules. And also notice that these are not caseating granulomas, right? You just have this open, empty appearing space within the granuloma. And the clinical significance of this is its association with the specific bug Corynebacteria species. And again, that's an easily boardable question, because anything they can show you and they can say, what's this associated with? And there's only one answer, is something you should remember. And they're very difficult to culture. It takes a long time to incubate, and often cultures are actually negative for this organism due to its scant, nature. And it's also very difficult to identify these on histology. You want to do a gram stain, all right? And if you do, you're going to see these small, gram-positive rods inside of that cystic space. But you need to know that this is difficult because often it's negative. I've done it several times. I haven't personally seen a positive gram stain in this case. Someone did mention in the comments, why don't you try a thicker cut on your gram stain to see if that helps identify them. And I'm going to try that next time. I think that's a good idea, and see if that maybe has higher yield. But the histology is so classic that you should report the diagnosis on the histology. So you don't have to say with Corynebacteria if you didn't see them, obviously, but you can still say cystic neutrophilic granulomatous mastitis. And if you really need to, you can do ribosomal formalin fixed tissue kind of RNA to see if you can find the bug that way. But clinicians are often going to treat just based on the diagnosis with a prolonged course of antibiotics. So moving on to case number 7, 64-year-old female with a history of bilateral mastectomy. Now she has a chest wall MRI that shows enhancement. And this is what you get, okay? And when you see this, you say, okay, that's a lot of cells. Kind of looks like it's infiltrating throughout the skeletal muscle here. This should catch your eye to go higher power. And looking on higher power, we have, really nice muscle cells here. And, a lot of cells kind of infiltrating throughout the skeletal muscle. And this is a difficult case because I wasn't expecting people to just straight out give a diagnosis, right? More of a differential. What could this be? What are some things that we need to think about in this scenario? So one, is this inflammatory? Is this carcinoma? What's the patient's history? Things like that. But look how these cells are kind of infiltrating as single cells kind of throughout the skeletal muscle. Very ugly. And on a different, area of the tissue, you can see again these cells are kind of infiltrating throughout. I think lower power helps you appreciate the size of these cells, right? If you're looking here, these are very small lymphocytes, and then you have these, which are much larger, okay? And so that should clue you in that, okay, maybe we're dealing with an epithelial neoplasm as opposed to a hematologic neoplasm, although that should still be in your differential. And again, you can appreciate the size of these cells kind of infiltrating as single cells throughout what is largely inflammatory cells. So this was a case I was hoping people would kind of give different ideas of what this could be, more of what is the next step, what should we do in a case like this where a patient clearly has a bilateral mastectomy previously, right? So first, the most important thing is history, right? What is the patient's history? But I think you have to have that information when you see a case like this, and many of the people point out in the comments that you need to rule out recurrence of a previous carcinoma versus a hematologic malignancy. And something that people brought up was breast implant associated anaplastic large T cell lymphoma. And that is a great differential. I think those are the two things you really want to think about in a case like this, because there's a pretty large inflammatory component. Didn't really see the hallmark cells, but anaplastic T cell lymphoma, if she had implants, right, that's something you definitely want to think about. This patient did not have implants. She actually had a resection previously for invasive carcinoma. So that's history, right? You want to look at that history. If you see a case like this, the first thing you want to do is look up the patient's history. Call the clinicians. Call the radiologist. Hey, I got this chest wall biopsy. What's going on? I don't have any history about this patient in my system. Turns out a little discussion, and the clinician says, oh yeah, she had invasive carcinoma 10 years ago in the right breast. All right, so that's good information. So it's good to think about what these things can be as you're moving forward. And in this case, if you can't get history, right, doing a couple simple stains will help you go out on the right path, right? Do a keratin, you can do a CD45, and then boom, this thing is diffusely keratin positive. You say, okay, it's carcinoma. Now we're going to go down that route. And so with the patient's history of lobular carcinoma, that's going to clue you in, okay, this is most likely a chest wall recurrence of infiltrating lobular carcinoma. In this case, pleomorphic type. These are pretty ugly discohesive single cells infiltrating throughout the skeletal muscle. This is actually a really cool image. This is a really impressive case of lobular carcinoma just really invading throughout the skeletal muscle. I mean, if you see the slide, it's really just everywhere, and it's just amazing how lobular carcinoma can do this. These single cells that infiltrate throughout, and you can understand why it's so hard to resect these lesions and even detect these lesions, because they're just single cells kind of infiltrating throughout until it gets big enough to cause a reaction or a mass. These are so difficult to jump to. But you shouldn't be, quick to jump to that conclusion, right? As I mentioned, just because the patient had a history, you really should do IHC in a case like this to support your diagnosis, because a hematologic malignancy should be on your differential in a case like this, especially, any things that are associated like ALCL in the breast, right, with implants, if she had an implant, for instance. So, but it didn't really have the histologic features really to support that anyway. Again, ALCL is really characterized by these hallmark cells, which are these anaplastic, horseshoe-shaped nuclei that have this reniform type nucleus. Very, very ugly, and they're also associated with an increased eosinophilic infiltrate, which we didn't really see in our case, right? There's no real eosinophils in this. It's mostly just chronic inflammatory, lymphocytes, I should say. But the characteristic feature, of anaplastic large cell lymphoma is the CD30 positivity. That's something that's very classically associated with these lesions. All right, case number 8 is a 56-year-old female with a 4 centimeter mass not present on the last annual mammogram. So we've had a 4 centimeter mass grow in 1 year. And this is what you get. You say, oh my goodness, this is clearly neoplastic, right? I'm not sure what this is. It doesn't look like ductal carcinoma. I just see this spindle cell proliferation on low power. So you go a little higher and you start noticing, okay, not only is the spindle cell lesion, just everywhere, it's also very ugly, right? We have very, very large appearing cells. And if we look even closer, You can see it's infiltrating into the fat here, right? Some of them don't look too ugly, but there's no pattern to this. It's just solid, sheets of spindle cells with mitosis, and maybe single cell necrosis here, infiltrating the fat. And on higher power, you start noticing, wow, it's really mitotically active, right? There's one, there's one, there's one, there's one. Here's a weird one. Maybe that's trying to be one. I don't know, but these cells are huge. So clearly, I'm saying, okay, well, I'm dealing with a neoplastic malignant spindle cell population. And that's all you really should have got to initially when I showed this case. It's a malignant spindle cell neoplasm. We need to work this up. And that's really that's all you can do at that point, just on H&E. So let's talk about though, and I have a one of my interesting cases of the month is on metaplastic carcinomas. I'll link that right here in the upper right for you, so you can check that out if you want to hear me talk about 20 minutes just about metaplastic carcinoma in general, more focused. But in this one, what I wanted to show was that this could be anything, okay, when you initially get it. But what are the first things that you should think about in the breast? And the first three things you think about in the breast when you see this are metaplastic carcinoma, and number three is metaplastic carcinoma. And why do I say that? I say that because you have to rule out metaplastic carcinoma in the breast when you see a lesion like this before you even really want to explore other options. And the most likely other option, if it's not metaplastic carcinoma, is a malignant phylloides. And much, much, much more rare is going to be a metastatic or primary sarcoma of the breast, okay? So what do you need to do? You need to order several keratin stains, all right? CK7, 5, 6, do a pan-CK, 818, A1, A3, 14, and 17. Do all of them because these lesions may only be focally positive for even just a few of those keratins, but that's enough. The ones most likely to be positive are your higher molecular weight keratins, okay? And if you see scattered positivity, then that is supporting that this is a metaplastic carcinoma, okay? Another useful stain is P63, which is going to be overexpressed in about 90%. So you should see nuclear positivity in these tumor cells. However, keep in mind that it can be negative. I have seen a P63 negative metaplastic carcinoma, but greater than 90% of the time, this stain should help you. They may also be positive for myepithelial markers, okay? And generally, these are going to be triple negative. Almost always, they're going to be triple negative ERPR HER2 tumors. Again, your main differential in a case like this is malignant phylloides, okay? And sometimes you can't make that distinction, okay? Let's say you get a biopsy that's just a malignant spindle cell neoplasm. You do not have to come up with that differential. You do not have to definitively call it a metaplastic or a malignant phylloides on biopsy, okay? Most likely it's going to be a malignant phylloides, but let's say you do keratins and all your keratins are negative, okay? That's okay. Just call it a malignant spindle cell neoplasm and wait for it to be excised. Because the P63 and keratin stains can be focally positive in these tumors, being negative on the biopsy doesn't rule it out, right? And a malignant phylloides should have a benign epithelial component somewhere, right, to it, or, one of my mentors said, in every malignant phylloides case I've seen an area of a hyalinized, fibroadenoma, or, a more non-malignant appearing phylloides area of the tumor, right? So that's something to keep in mind. But if you have a biopsy that's just purely the spindle cell component, you may not be able to make that distinction. You may not have the histologic features that push you more towards a phylloides. So in those cases, I'll just say, hey, malignant spindle cell neoplasm, see comment in the comment, all these things were done, everything is negative. The differential includes a metaplastic carcinoma versus a malignant phylloides tumor, and let it come out and then assess it further once you get the excision of the whole lesion, right? So keep in mind, you may not be able to distinguish these two lesions on biopsy, and that's okay. Case number 9 is a 43-year-old male with a well-circumscribed breast mass. And you can see this lesion. So you see this, it's kind of a well delineated lesion, okay? On low power though, clearly you have some cell population kind of infiltrating the fibrous tissue here. And again, this is a male patient. And if we look a little bit closer, it just looks like some haphazard arranged spindle cells kind of with this dense maybe collagen in between them. And looking a little higher, again, it looks the same. Very bland nuclear features, okay? These are very bland cells kind of infiltrating throughout the tissue here. And again, it was well circumscribed on the lower power. And these kind of haphazardly arranged spindle blue cells are kind of separated by this kind of thick bands of collagen. And again, this is a great picture here. If you see this picture and the picture prior, you should be able to get this diagnosis. This is a recognizable lesion that easily could be tested, I think, and this would be a fair one. But again, no mitoses, very bland nuclei, kind of just little groups of it in haphazard arrangement, kind of going everywhere, again, separated by this dense collagen, right? Really nothing other than the, you know, clearly this is some sort of neoplasm in the sense that it's not normal, right? It's not normal to have this proliferation in the breast. Other than that, there's really no malignant features to it, right? So no necrosis, no mitosis, no significant nuclear pleomorphism, no nuclear irregularities, nothing like that. And again, this is an example of a myofibroblastoma, which is a benign spindle cell neoplasm characterized. It's very, again, like I mentioned earlier, imaging is huge. Okay, you really should correlate your breast biopsies with imaging, and these should always be a nice, well circumscribed mass. And I think the thing about this lesion that could be boardable is that it has similar frequency in males and females, which is actually why I showed this case. This case was actually very interesting because this was a benign myofibroblastoma that was picked up on a guy who actually had contralateral breast cancer. That was a very interesting case. But it used to be thought that these lesions had a higher propensity in males, but over time it's now thought has about equal frequency in males and females. It's uncommon. It's typically going to be seen in older patients. Again, very well circumscribed borders, uniform spindle cell proliferation arranged in haphazard intersecting fascicles interrupted by thick bands of collagen. This right here is a classic picture. If you see a picture like this without my name on it, hopefully, then that's what you need to think about in the breast. Well circumscribed mass with this kind of histology is a benign myofibroblastoma. Now, these lesions do actually show the same chromosomal loss as spindle cell lipomas, and it's thought maybe that these are actually variants of the same tumor, and that's a very interesting thing. But, spindle cell lipoma should have more abundant adipose tissue compared to a myofibroblastoma, so you're not really going to call that in the breast if it just has this nice classic histology. Refer to it as a myofibroblastoma. These are going to be positive for CD34. That's a good stain you can use. Generally going to be positive for ER and PR, as well as muscle markers, Desmond, and SMA. All right, so moving on to case number 10, a 57-year-old with a irregular mass. And this is what we see here, okay? On this power, you can see some ducts over here, probably looks like just some UDH. And then we have these nests of cells, which actually look a little bit more pleomorphic. This one's touching the fat here, as I've mentioned in several of my cases and several of my didactics. That's generally not a good thing. And if we move to other areas of the tumor, again, we see it kind of going out into the fat here. That's, obviously indicative of an invasive carcinoma. Let's look a little bit closer at the cells themselves because something's interesting about these, right? They have more clear cytoplasm than what you typically are used to. And if we look, they actually do. A lot of these have very clear cytoplasm. The nuclear pleomorphism is pretty striking. I do believe there's some mitoses scattered throughout here. These are solid, kind of nested tumor, kind of a 3-2-1 type deal so far. And again, you can see, look at this abundant clear cytoplasm. But take note about this. This is actually pretty interesting. Is this kind of like almost like a little granular. It's not totally clear. Some areas have a little bit of speckling to the cytoplasm, and that's actually a feature of this lesion. Is it's not completely just solid clear cytoplasm, but it has this almost granularity to the cytoplasm. And this was actually an infiltrating, a moderately differentiated ductal carcinoma with clear cell glycogen-rich features. And it can be a little strange when you see it, and you may wonder, is this in situ? And I think some people in the comments originally had said that, is this like a weird, lobular in situ involving lobules? That's kind of odd. And I think that's a good thought because it does have, when it has this abundant clear cell glycogen-rich cytoplasm, it kind of throws you off a little bit. You're kind of like, that looks a little strange. And that's fair. It does. It looks a little strange when you see it because one, it's rare. You're not going to see this very often. But take note again again, as I've mentioned, of the tumor infiltrating the fat. That is always something I look for. If I see stuff going into the fat, that's generally never a good thing. And also, go back, step back to low power. Low power is your friend in the breast because, one of the things that was taught to me by one of my mentors, he said, look, I look at low power and I just envision if I were to inject tumor into a lobule, could it create this pattern? And what he was basically telling me was, do you think this has a lobulocentric pattern? And if it doesn't, then you need to start thinking, okay, maybe like there's no way I could inject a lobule and blow up all the lobules and the duct and get this kind of pattern. I just don't see that as happening. Then you say, okay, then it's lacking a lobulocentric pattern, and that's generally not a good thing, right? And these invading as this solid pattern, those are tricky cases. When you have these cases that invade in these like solid, really well nested patterns, those are tricky, especially when they're very large. You see cases that you look at and you say, oh, I think that's DCIS, and it ends up being invasive just because it has this invasive pattern. And this glycogen rich is one of the things that produces this type of pattern that can be difficult. And, they have this kind of characteristic clear cytoplasm. And again, as I pointed out in the previous slide, if you take a look, you can actually see this slight granularity to the cytoplasm as well. This is rare. And just like other, special types of carcinomas, this has to comprise at least 90% of the tumor cells displaying this histology to be called clear cell glycogen rich features. Another differential that was brought up in the uh, comments in this particular case was microglandular adenosis or carcinoma arising from microglandular adenosis. Again, that can happen, and I think that's a very good thought. But again, ER, PR, S100 are going to be your friends here. This case was ER positive. Atypical MGA should still show areas of classic round tubules, right? With a little bit of more nuclear pleomorphism, maybe some complex architecture where they're elongated or crowded. And I've seen a case where it went from, classic MGA to atypical MGA to carcinoma, and you actually can see that transition. So it typically doesn't have these large solid nests with clear cytoplasm. That's not something you generally see. So keep that in mind. The stain you want to do that's interesting in this case is PAS with and without diastase. When you do that, the PAS will highlight the glycogen granules that are diastase sensitive. So when you do it with the diastase, it's gone, as you can see here. Really cool case. The histology is so fun to me. I mean, someone said I don't like it when people, say, oh, this is a beautiful image or a beautiful case. And, to me, if you're not enjoying what you do, if you don't find these kinds of things beautiful, then you probably don't like pathology, right? I mean, you have to enjoy the art of it and enjoy seeing things. Of course, we know there's a patient on the other side of this, and we're always cognizant of that. But it's our interest in disease and our interest in the way things look and our interest in the way things stain and how they're different from other things that really make us enjoy this profession, right? And I think that, sometimes people forget that it's okay to enjoy what you do, right? So clear cell glycogen rich carcinoma has a similar prognosis to just infiltrating ductal carcinoma, no special type, stage for stage, right? So this particular case actually had a lot of lymphatic invasion and positive lymph nodes. It was a very interesting case. All right, so moving on to case number 11. I didn't give any history with this case. I just said it was a 47-year-old female, and this is what you got. All right, you got a lobule here, right? Got a terminal duct lobular unit. You can see that maybe there's some periductal chronic inflammation, and then in the stroma, looks like there's some pretty large atypical cells out throughout the stroma. And again, you can see that, here's a TDLU up here. Looks very normal. It's got a myophyseal cell layer, nice luminal layer, very small, just like you'd expect to see it in a benign breast. And in the stroma here, you have these kind of more large, kind of bizarre looking cells. So I kept showing you a few images again. You can see them up here. That's kind of what I wanted to catch your eye on. I wanted that to catch your eye and say, well, what is that? Very multinucleated, right? Very small, uniform nuclei, no stromal reaction. These are in the stroma, doesn't particularly look, uh, you know, like it's causing any harm, right? There's no reaction to it. These are just kind of hanging out in the stroma, doing their own thing. And this is totally benign. And this was actually shown during Breast Cancer Awareness Month. And then another person on the Twitter family showed a case and said, for Breast Cancer Awareness Month, I wanted to keep it benign. So I followed suit and I said, look, let's go benign this month because what she's absolutely right. The majority of cases that we see in breast pathology are benign. And a lot of the times, I think residents and people learning pathology focus on malignant and focus on malignant, right? But you have to think about all the benign things, right? Because you don't want to get tricked. And this is something that when you've seen it, you don't really forget it. Okay, it's not uncommon, I should say. It's not like super rare that you see this, but and when you see it for the first time, you're kind of like, oh, that's wow. What is that? And these are just benign multinucleated stromal cells. It's thought that you can see these in association with fibroadenomas or even phylloides tumors, but the important thing is to notice that these are normal constituents of the breast stroma and not to interpret these as atypical, start staining these, trying to figure out what they are. Even though they are said to be associated with fibroepithelial lesions, I've seen this just in benign breast tissue that's just totally benign and there's nothing, no lesion around it, right? I mean, there's really no lesion around this, right? It's just kind of normal breast stroma with some multinucleated stromal cells. One of the theories is that these are seen due to degenerative changes, but ultimately, I think again, I don't think we really know. I just think the biggest feature is to know that they're benign, right? The biggest mistake you can make is interpret these for invasive cells, but look at a few things so you don't, make that mistake. And one of them, again, as I mentioned, there's no stromal reaction. Okay, they can be hyperchromatic just because there's so many nuclei in a small space, but each nuclei has a very smooth contour, lacks any nuclear atypia or mitotic activity. So check the surrounding tissue. If there isn't anything in the surrounding breast that hints to any malignant lesion, then back off. Like why would these be here if there's no DCIS, there's no stromal reaction, there's no mass, right? Radiologic correlation, right? You got to correlate radiologically. But lastly, if you're totally unsure, just throw a keratin at it, and it's going to be keratin negative, and that if that'll help you rest, say, oh, I just want to be sure that I'm not missing like some sneaky infiltrative lesion, then throw a keratin at it, it'll be negative, and go to sleep. All right, case number 12, 57-year-old female with a 7 millimeter mass. And again, we were doing our benign month here. Okay, so I'm already telling you this is benign. But what do you know on a lower power? Okay, lower power, very well delineated lesion. Okay, and it has all this kind of adenosis throughout it. There's a lot of sclerosis as well. And if you look on higher power, again, you can kind of see these glands kind of going out, these small little tubules. A lot of the stroma is sclerotic. This case is associated with calcifications, as these generally are, okay? But these glands, if you look at them, it's a little difficult to appreciate. I mean, let's go a little bit closer, and you'll see what happens as you get closer and closer in these lesions is it becomes more difficult. So now we go even higher power, okay? And now it starts to look really scary. So, well, man, now I've got these cells kind of infiltrating the stroma. Is that a myoepithelial cell there? I'm not sure. Is that a myoepithelial cell? I'm not really sure. So here's the key. Okay, the closer and closer you get to these lesions, the more difficult you're going to have with you're going to have more trouble delineating what's benign and what's malignant. That low power image I showed you with the well circumscribed border, the adenosis with the sclerosis is what you need to know, because this lesion is a pitfall. When you get closer and closer to it, you start wondering like, oh, is this invasion? You know, is there myopithelial cells around this? And this can be a pitfall because if you do myopithelial cells markers, indeed there could be areas that are negative, not because myopithelial cells aren't there, but because they're not staining. They may be too attenuated from the sclerosis. So you have to be very, very careful in these lesions, right? You start seeing these irregular, is that a single cell, What is going on here? The closer and closer you get to sclerosing adenosis, the more difficult you're going to have making the distinction between benign and malignant in these entities. You need to take a step back and look at the low power image and notice the maintained lobulocentric pattern. And that's indeed what this was. This is an example of nodular sclerosing adenosis. And nodular sclerosing adenosis generally is going to be encountered via clustered calcifications. These almost always have calcifications, but it can be mass forming, as in this case. So in this case, if you just sign this out as sclerosing adenosis, okay, that may be interpreted by the radiologist as not concordant. Okay, because you're not explaining the mass, right? So you need to know what they're going after. And if this is your lesion and it's a large lesion of adenosis and sclerosis, very well circumscribed, and you can say, okay, I think this is likely mass forming, then you can say nodular, right? Nodular sclerosing adenosis, because now you're explaining the mass. Like, you have a nodule of sclerosing adenosis that I think likely is producing the mass that you're seeing. Because if you don't call it nodular sclerosing adenosis, you just call it sclerosing adenosis. Generally, just sclerosing adenosis is not mass forming, and they may say, well, maybe we missed it, maybe we'll rebiopsy, things like that. So you need to again, correlate what they're saying radiologically with what you're going to say to make it make sense. And as I mentioned many times, one of the most important things in breast pathology is correlation with that radiology. Okay. It presented with cluster calcifications and a 7 mm ovoid mass. It's important to know that sclerosing adenosis can present as a mass, okay? But it's not really a tumor. One of the old terminologies was adenosis tumor, okay? Don't use that terminology. It's an old term. I think patients read that, I got a tumor, it's not a tumor. Don't use that. It's just important to make that distinction between nodular and just classic sclerosing adenosis so that the radiologists know that they're in the right spot. The pitfall with sclerosing adenosis is this misinterpretation of invasive carcinoma. We don't want to make that mistake, right? Again, you want to notice the classic lobulocentric architecture as well as the well-circumscribed border. Generally, when things have a well-circumscribed border in the breast, it's benign. The only thing that's not is generally really fast-growing tumors, and those are going to be very ugly and highly mitotically active, and you generally aren't going to call those benign. So if it's a lower grade thing and it's well-circumscribed, start thinking about benign entities first, okay? And the lumina are often distorted and compressed by the stromal hyalinization. So if you do myopithelial markers, just be very careful, because again, those can show reduced expression, as I mentioned earlier. Interestingly though, sclerosing adenosis shows increased estrogen receptor expression compared to the normal breast. It's very interesting. But as you can see over here, the P63 is showing nice staining throughout it, throughout this lesion, and the ER is actually pretty strong in the sclerosing adenosis. It's actually classified as a proliferative lesion and carries with it a 1.5 to 2 times increased relative risk for the development of invasive carcinoma in the breast. And that's an important thing to keep in mind if you are studying for the boards. They like to ask you risk associated with lesions, so keep that in mind. So moving on to case number 13, 49-year-old female with a lobulated mass. And I showed you this image. And these are difficult cases. I'm actually working on a lecture to help you with these lesions right now, and hopefully I'll get that uploaded maybe in the next month or so. I have the new board coming, so I don't want to guarantee anything. But look at this. This is a great example of what is called leaf-like architecture. Okay, you can imagine this being a leaf that you might see falling from the trees in the fall. So notice the low power. So it kind of has a very compressed glandular structure, right? And a lot of kind of a stromal, there's a lot of stroma here, right? What we don't want to call it, we're not going to call it stromal overgrowth, and we're not going to use that terminology. Those are specific to things, but this has a stromal proliferation, okay? And that stromal proliferation is compressing the epithelial component of this lesion. So there's a couple things that are on your mind, right? And those are the spectrum of fibroepithelial lesions ranging from fibroadenoma all the way to malignant phylloides tumor. And that's where you want to be. So you say, okay, well, I'm on this fibroepithelial lesion. Now I need to decide, what do you need to decide at this point? Okay, this is a biopsy. What do you need to decide at this point? What you need to decide is, does it need to come out? As we've talked about earlier, this is a screening test. When you see a biopsy, your decision tree is, does this need to come out or does it not? And that should be the basis of the decisions that you make to make your diagnosis. And in this case, let's look at a few things. Well, it's got this compressed gland here. This is what's called stromal subepithelial condensation. Okay, this is subepithelial condensation, right? So if you look at the stroma here, it's a little looser. Okay, and then as we approach the epithelial, totally benign looking component of this lesion, it's looking a little more cellular. Okay, so that increased cellularity underneath the epithelium is what we refer to as subepithelial condensation, and this lesion actually displays that pretty nicely in the areas that I'm highlighting. And then other areas, not so much, right? The subepithelial condensation is not as prominent here. And that's the thing with these lesions is that there can be areas that lead you one way and areas that lead you other, and you start being on the fence and you know, I'm not really sure, and you kind of debating it, right? But we need to put everything together. Every piece is just a piece of the puzzle that we're all going to put together at the end to formulate our diagnosis. So what can we take from this image? Well, what we can take from this image is that the nuclei are very bland, little bit of stromal, very, very, very mild cytologic atypia, right? Generally, you have some mild cytologic atypia in these lesions, but this is nothing that I would consider, right, a malignant stroma, right? This is not that. And you'll see at the end, that's really the distinction you need to make. Is it malignant or is it not appearing? Because generally, some cytologic atypia is okay. Like right here, this nucleus in the stroma is a little bit atypical. And you can see that here too, right? A little bit atypia. But what do we not see? We don't see mitoses, right? I'm showing you no mitoses in this stroma. I don't see a single mitoses. Again here, we do have a little bit of stromal subepithelial condensation, maybe very, very mild cytologic atypia of the stroma, but again, no mitotic activity. And even higher power, be careful with the endothelial cells, right? You don't want to interpret that as being very atypical, but again, no mitotic activity. So what did this case represent? This case was actually an example of a benign phylloides tumor. And I think most people struggle with classifying and then differentiating phylloides tumors from cellular fibroadenomas. And that's completely understandable because both of them arise from fibroblasts of specialized intralobular stroma, and some phylloides tumors may arise from a pre-existing fibroadenoma. Also shown, studies have shown that fibroepithelial lesions, including fibroadenomas and phylloides tumors, have shown the same recurrent MED12 mutations. So clearly, we're really actually on a spectrum of an entity rather than distinct entities, right? We're on this spectrum from, a very benign classic fibroadenoma all the way to a cellular fibroadenoma to a benign phylloides to a malignant phylloides, right? But the distinction between a cellular fibroadenoma and a benign phylloides can be extremely difficult, especially on a core biopsy. And that's why we use the terminology fibroepithelial lesion. That's the whole reason that kind of terminology was brought about on the biopsy. And I'll talk about that briefly, and we'll talk about that in a lot more detail in my lecture coming up that hopefully will be up in the next month. But let's talk about a few features to help you make the distinction between a phylloides tumor from a cellular fibroadenoma. And what is the clinical difference, right? If you call something a cellular fibroadenoma on biopsy, that says, hey, you don't necessarily need to take this out right now. Now, some patients may actually request it being taken out for cosmetic reasons or they're uncomfortable, and that's totally fine. But, as opposed to a phylloides tumor, or if you call a fibroepithelial lesion, then you're saying you take this out, right? That's the difference, okay? So on biopsy, what are we looking for? Well, first look at the architecture. Fibroadenomas typically still have open glands, all right? They're typically not compressed, causing that leaf-like architecture that you see in a phylloides tumor. Okay, and the cellularity in a fibroadenoma is generally going to be relatively uniform throughout the lesion. What you're not going to see is the subepithelial condensation that you see in phylloides tumors. That's a feature to help you as well. Stromal overgrowth is a feature, okay? And stromal overgrowth is really considered, when you have a 4x field that's occupied by just stroma, okay? And that's really going to be a feature in higher grade phylloides, but it's something you should never see in a fibroadenoma, okay? If you see a lesion with a 4x field that's only stroma, then it needs to come out, all right? Stromal nucleopleomorphism generally is going to be absent in a fibroadenoma. What could you see in a fibroadenoma? Benign multinucleated giant cells that I showed you in the previous case. Don't consider that stromal atypia, as I mentioned in that case, right? So you can see giant cells in the stroma of fibroadenomas, and that's okay. It's not necessarily atypical. Whereas the stromal cells of even benign phylloides, as in our case, typically will show some mild to moderate nuclear atypia, and then as you get on the more malignant, scale, you'll see sarcoma to stroma, right? Stromal mitoses should be absent in a fibroadenoma, and as you have, even in a benign phylloides, you may have a mitosis here or there, But increased mitotic activity just in general is more suggestive of phylloides tumor than a fibroadenoma. And as you get to as you get more mitoses greater than 10, then that's going to push you as an atypical feature, right? And then the tumor border of a fibroadenoma is generally nice and well circumscribed, the pushing border, whereas a phylloides tumor is generally microlobulated in lower grade. Higher grade can actually have infiltrative borders into the fat, right? But that microlobulated architecture is something you see in a phylloides tumor, whereas fibroadenoma is generally nice and smooth, round, and well circumscribed. And actually, my PA teacher, when I was a resident, she used to describe the gross description of phylloides. She used to say they have these bulbous protrusions, and I thought that was the greatest gross description of a phylloides tumor, and I always use it ever since. This X by X centimeter mass with bulbous protrusions. Basically I'm saying it's microlobulated. So you can imagine that on biopsy, it can be very difficult to make this distinction, right, between a cellular fibroadenoma and a benign phylloides. As one, you may not see the border, you may not see the mitotic activity, and you may not have other features that push you to saying this is definitely a phylloides tumor. It depends on where, maybe it's a 4 centimeter mass and they just hit one region that just didn't show those lesions. And using the terminology fibroepithelial lesions in these cases is okay. And it's essentially going to tell them you need to take this out to excise it so we can better classify it. The other school of thought is if you're on the fence between a cellular fibroadenoma or a benign phylloides and you can't really make that distinction on the biopsy, and let's say you're hedging more towards, fibroadenoma. I mean, if you're worried, if there's tons of stroma and it just has the other features that we talked about of a phylloides, but you're just not willing to call it a phylloides, that's okay. It's fine. Just call it a fibroepithelial lesion and get it out, right? But if you're really more towards the cellular fibroadenoma range, but you're not totally sure, the other school of thought is say, well, just call it a cellular fibroadenoma and put a comment in. And that comment can say, although a cellular fibroadenoma is favored, a benign phylloides tumor cannot be entirely excluded. And what this does is it gives the clinicians room to assess for interval growth. And interval growth really is the best indicator of phylloides tumor versus fibroadenoma clinically, right? If a lesion doesn't grow in like 6 months, it's probably just a cellular fibroadenoma. But if it grows a centimeter, then it's probably a phylloides tumor and they can go ahead and take it out, right? And that's something that will give the surgeons a little bit of leeway to prevent unnecessary surgery. So another thing that is grading, and this is the criteria from the Stanford Surgical Pathology grading criteria that is strictly from them. It's just copied from their website. You can go check it out as well. And I think that their grading criteria is perfect in the sense that it's going to give you a very systematic and objective way to grade these lesions every single time. So what I do when I get these lesions is, one, I look for adverse features, especially on biopsy, because if I see any adverse feature on biopsy, it's coming out, right? You're already into the borderline character, category. And I'll say that in the comment, this is an at least borderline phylloides tumor in the comment, right? To let them know, hey, this needs to come out. So the adverse features are stromal overgrowth, which is one 40x field without epithelium, 40x being your 4x, objective and your 10x eye field. And then high mitotic index, which is greater than 10 mitoses per 10 high power fields, sarcoma to stroma, and infiltrative margins. And by using those adverse features, now you can classify it as benign, borderline, or malignant. Benign being there's no adverse features. These have the 20% recurrence rate after local excision. It's generally recommended that these get wide excisions, right? But a lot of the surgeons will actually shell these out because, one, they may not be sure that it's a phylloides tumor. I think as we're getting more and more into it, people are saying, hey, be sure you get a good margin around phylloides tumors, because it's shown that if you get at least a centimeter margin, you have a lower chance of recurrence. Often I just put in the comment that the biological rate of recurrence cannot be, accurately predicted, right? We have these percentage, but it's basically saying, hey, follow the patient, right? This could recur. You can put the percentage in if you like, but I don't typically like to do that. Then borderline is when you have one or more adverse feature, but you fall short of the definition of malignant, which we'll talk about in just a second. Again, higher rate of recurrence after local excision than benign. And then when you get to malignant, you're going to call it if you have the high mitotic index, right, greater than 10 per 10 fields, and a sarcoma to stroma. If you have those two features, you're already going to be calling it a malignant phylloides tumor. Or you have stromal overgrowth. All right, so now we have one of your 4x objective without epithelium, and either the high mitotic index or a sarcoma to stroma. Okay, those two we're going to push you to a malignant phylloides tumor. Okay. These again have a higher rate of recurrence after a local excision. Generally, the good thing about all these lesions is that the treatment is the same, right, to excise. Radiation is debatable. It's something that gets brought up in tumor boards, depending on the size of the lesion. Should we radiate this patient, things like that. But generally, surgical excision is the management. All right, so let's look at our final case, which is a 64-year-old female with an 8 millimeter spiculated mass. And the radiology is important, right? Spiculated masses are generally not good things. Okay, that's one of the buzzwords you're going to see in radiology. Spiculated. If you hear spiculated, you're already on the okay. You got your radar off. You need to pay attention. And what do we see? Well, we see really a reactive stroma in here. Okay, we've got clearly these glands infiltrating, really no pattern to them, lots of calcifications. Going a little higher power, if we look at these tubules, they lack a myoepithelial cell layer, right? It's a single cell layer, has a very angulated edge to these tubules, but again, they're nice and really well-formed tubules and a very noticeable desmoplastic response with calcifications in the tumor itself. And we look here, we can see again these tumor cells are actually infiltrating into the fat. As I've mentioned several times, that's never a good thing to have tumor cells into the fat. Lacks a myoepithelial cell layer, has these angulated tubules, and this really dense desmoplastic response. So you should, at this point, say, okay, I'm dealing with a carcinoma. I'm dealing with an infiltrative carcinoma. Why? It infiltrates the fat. It lacks the myoepithelial cell layers. It has a desmoplastic response, right? So that's a key feature to differentiate it from the other thing that may look similar that doesn't have, that isn't carcinoma that we mentioned earlier, microglandular adenosis, right? Calcifications, desmoplastic response, angulated tubules going into the fat. Again, you can see another feature of this is having these tubules kind of infiltrating around benign ducts. Okay, this is probably just I wouldn't call this DCIS or anything, right? This is probably just some epithelial hyperplasia. It has this kind of almost micropapillary pattern, but it's not a DCIS. These are actually infiltrative carcinoma kind of invading around this duct. Again, calcifications, no myoepithelial cell layer. And this is a case of tubular carcinoma, and most people are right on point with this. And these are pretty classic pictures for tubular carcinoma, right? It's going to be very small. These are very slow growing. The majority of these are going to be less than a centimeter in size, and they have a great prognosis. Very low metastatic potential. They almost never have positive lymph nodes, and because they're slow growing, they're often associated with calcifications, and in fact, they may actually be picked up by calcifications. So keep that in mind. But the majority are still going to be detected as a mass or a distortion. But just keep in mind, if you get a calcification case, this is something that you could see. And, this was, as I mentioned, this is our last case of the week. It's going to be, we'll take about a month off. My third son is actually due just in a couple days now. We're getting so close. I'll be sure to show you guys pictures when he's born. Wesley Thomas, very excited, be the third boy. So very, very excited for that. Again, these tumors, as I mentioned earlier, have a very low metastatic potential, excellent prognosis. Honestly, they're almost always cured by a complete excision with negative margins and endocrine therapy. They don't basically show any response to chemotherapy, which is expected. They're not really mitotically active. And these should always be strongly positive for estrogen receptor. If not, double check your diagnosis. As I mentioned earlier in the MGA case, if you have something that is well-formed tubules and it's ER negative, you need to double check the diagnosis. But, again, MGA shouldn't have the histology. The histologic features, as I mentioned, are different with the desmoplasia, the angulated cells going into the fat, right? All that, all those things are again, pieces of the puzzle to help you come to the right diagnosis. Every little thing that you learn is just a piece of a puzzle to look at the whole thing together and bring it together however you systematically want to put it together to reach the right diagnosis. And what are those features, right? Again, as I mentioned, well-formed glands, haphazard pattern, lacking a myoepithelial layer, small uniform nuclei. The lumens are generally open and angulated and infiltrating into the fat. But take note of that desmoplastic stromal reaction. Tubular carcinomas always have a very noticeable desmoplastic reaction. And this is a special type of tumor. Just like our other special types, greater than 90% of the tumor should show this morphology to be classified as tubular carcinoma. So on a biopsy, I'll just say tubular features, right? Infiltrating infiltrating well-differentiated ductal carcinoma with tubular features. And again, take note of the tumor going to the fat. That's a key feature. This is this is actually a image that was taken by Patrick McIntyre, who shared this with me with his permission. You can check out his Twitter at Pat McIntyre MD. He's a breast pathology fellow right now, and one of the things that's testable with tubular carcinoma that he's able to show in one image, I've never actually seen it in one image other than books. It's hard to actually get one field that shows all of it, and that's Rosen's triad or Rosen triad, which is an easily boardable question. They can say, what is, Rosen triad? And what it is it's association of tubular carcinoma with columnar cell changes and lobular neoplasia. Okay, so that's Rosen triad, and this is actually a beautiful picture by Patrick. So I appreciate you sharing that with us. The most frequent genetic alteration is 16q loss and 1q gain with tubular carcinoma. Also, I want to show you some excellent annotations that were done by Dr. Rolla. She told me just to say Rolla. It's hard to pronounce her name. So you can also check out her Twitter at Dr. Rolla Ali. She responds to a lot of these cases of the week and has excellent annotations. And I said, hey, can I actually use your annotations for the actual presentation of putting this together? She said, yes, please do. And so thank you so much for that, because this is really great. I'm not as artistic, I think, but she shows this very, very nicely, because her response, right, I haven't given the answer yet at this point, and this is her response as to why she's calling it tubular carcinoma. And it's such a great explanation, because she shows everything that I wanted people to notice. And again, I purposefully take pictures to show you things purposefully. I want you to see the things that you need to see. All right. And she saw everything. It was great. Glands infiltrating around the ducts. She said that, single cell layer, open lumens, the cellular stroma, the desmoplastic stroma that I was showing you. She even mentioned the calcifications, which are a feature I think you need to use, the infiltration into the fat, the tapered angulated glands, and as well as the apical snouts and some of the tubular cells themselves. You may or may not see that, but I thought her annotations were actually beautiful. It illustrated the entity very nicely. I think, these are the type of responses that I love to see when people really engage, take the time, and look for the features that I want you to see. So excellent job, and thank you so much for allowing me to include this into this presentation. I think other people will also find these annotations extraordinarily helpful. So thank you so much, and again, check out her Twitter. She posts a lot of great stuff. So that's going to be it. That's going to wrap up the first season of our Don't Rush Breast Case of the Week. So I think I'll try to do a compilation maybe every 14 cases or so, because that's 14 weeks. So I think that's a good idea to do 14 weeks. Give me a couple weeks to put together a compilation and take some time to get ready for the next season. So I think that's kind of the roadmap I'm going to use from going on, from here. And I hope you enjoyed the cases, and more importantly, I hope you learned something. I hope you found it helpful. I do have a board review up, so if you guys want to check that out, I'll show that right here. Anybody preparing for the boards, check that out. I really cover a lot of stuff in 2.5 hours, so bring a coffee. Like, subscribe, hit the bell button to be notified when I upload new cases and new lectures. Appreciate all the support everybody's been showing me thus far. It's been really, really great. The Twitter has been growing. The Don't Rush Case of the Week has been growing rapidly. It's been fantastic. So I really appreciate all that, and I hope you guys are finding these lectures useful. It's something that I enjoy doing. I am in private practice. I kind of do this for more of enjoyment than academic responsibility, right? This is something I enjoy to do. I enjoy teaching. I enjoy showing breast cases, and just enjoy breast pathology in general. So I really hope that you guys are enjoying as well. So leave a comment. If you have any questions, I'll be sure to respond. You can also follow me on Twitter at @DamronMD. That's where we actually do the breast cases of the week, where I post them on Wednesdays and I post the answers on Fridays. So I hope you guys liked it. Again, we'll see you around. My next actual lecture coming up is on fibroblastic epithelial lesions. I'll try to get that up in the next month or so. So we'll see you around. Hopefully we'll see you on Twitter, and we'll see you at the next Don't Rush Breast Case of the Week.